not hematocrit, but creatinine is what I'm trying to say, creatinine. God, hematocrit's creatinine.
0.7 to 1.4.
Okay. In my head, it's 0.6 to 1.2. Because, no, but you go by Northwest Labs. But in my head, that's what it is.
Yeah,
That's,
it's 0.7.
Yeah.
anyway, you notice it going 2, 3, 4, 5. CVP is going 12, 14, 16. We're probably going to have to start some dialysis on them at that point, okay? And we would put a VAS cath in. We usually put it in the femoral area or up here, IJ, intrajugular. And we'll start CRRT. Now, the reason why we don't do traditional dialysis is what we call it. Y'all haven't had that lecture yet. But the reason why we don't do the dialysis where we pull everything off at one time is because studies have shown when you pull off a trauma and burn patients real quickly, they lose their volume and they die. It's a higher death rate with traditional dialysis versus CRRT. CRRT is continuous renal replacement therapy. That means that it goes all the time, 24/7, and it pulls off whatever the desired amount is, like 250 cc's an hour versus 3 liters in an hour. You see what I'm saying? Okay, so we would put them on CRRT. And usually when we start that, there's so many cytokines. Y'all know what cytokines are? Y'all never? Toxins, exactly. You have toxins in the blood because you've got a burn, and they're trying to fight that, and you know we've already got infection starting. I can tell you that right now. So you're going to clog that filter up, and you can see it. It's just like one big like clot of and it's cytokines in that. It's toxins in that. So we have to change the filter out a couple of times on those before we really get it going good. So, any questions?
As far as us covering them up, we're going to be using sterile blankets, right? Or do we use regular sheets, or?
Actually, I'm going to tell you right now, we would not cover him up with a blanket or a sheet right now.
So do we just keep the room like 80 something
That's
degrees then?
we keep that. That's where we go back to why we keep this room. We keep this room so hot. We can't. What can we cover him up with? There's not really anything we can cover him up with. Now, if you hand me those two packets right there, I'm going to show you what this is. Now, if he had a burn on his back, okay, this is called an Exudry. And what this is we lay our patients on these are very expensive. So don't tell anybody I took them. These are Exudry sheets. They lay on these sheets.
So it doesn't stick to
So it doesn't stick to them, and the drainage can go down in there. Do you know what I consider this? You always pads.
ABD pad?
They're just like an always pad. It's that layer that keeps, you know, the
yeah.
Top layer dry.
yeah. See,
It's
guys don't know that.
It's like so it's just got tiny perforations in it.
Do it now.
Just tiny little perforations.
Yeah, tiny little perforations in it, and yeah, take a picture of it. And we keep our patients on these when they've got burns on their back to keep that drainage. It helps keep that away from them, reduces the risk of infection. Now, I have a vest the same way. I'm keeping y'all too long, aren't I? You're good, okay?
They don't matter.
This is a vest.
Okay.
We'll put this over the patient. Use the other side against the wound. See, it tells you exactly what to do. So we would put this over him like this. And that kind of helps keep him covered up a little bit. And we have them for legs, we have them for arms, we have them for everything. These are just so expensive.
So the skin doesn't stick to it.
Skin doesn't stick to it.
So how often do you change these?
Depending on
How much is so?
The Exudator.
at least once a shift. At least once a shift. We tend to do a really good wound. We do wound care once a shift at least. If it's somebody new out of surgery, it may be 2 or 3 times a shift. And y'all, when you, and this is like a real, this is truly like a real patient as far as like picking the leg up. I'm gonna show you something. I got that dirty, that's okay though. I'll put this right here. When you're doing wound care, you don't always have help. Always. So you have to say, this is why we, in isolation gowns. Isolation gowns are gonna be for this patient every time. Okay, so that's your infection control story of the day, little rule. Anything over 20% is you're gonna be in isolation. Contact isolation is what it is. You're gonna wear a gown, you're gonna wear a hat, that's why I wear these hats. You're gonna wear a mask because they're so immunocompromised, okay? But what you have to do is sometimes you have to pick that leg up. You'll start wrapping and you'll wrap all the way down. And it gets heavy. And guess what? It may bend because they're knocked out. Pain control. We hadn't even talked about pain control, have we? Pain control. You think he's gonna hurt?
Yes.
Beyond hurt. You think this is gonna be painful?
Well, the nerve
Probably
endings.
not. This is probably not going to hurt as bad as probably what some of the second degree is.
Right.
Okay.
It's the nerves involvement.
Yeah, because they're destroyed. The nerves are destroyed. Okay, so we give fentanyl, we give morphine, we give Dilaudid, and y'all, you if you ever go in there and you see 10 of morphine given, don't freak out because you know your normal dose is 2. These patients come in a lot of times. We have drug addicts that you no matter how much meds you give them, you're not going to give them any satisfaction. I can tell you that. You can tell a drug addict. You can give them 400 of fentanyl drip, and 400 is your max dose. And I mean 400. Look, 50 would knock me on my rear end. So you're looking at 400. You'll give them Versed. What is Versed? Do y'all know what Versed is? Midazolam, and what is that?
As a benzo?
It's a benzo, and we give Versed. They'll be on a drip, and if we're doing wound care, we'll give them an additional IV push to a Versed. And Versed is what they give a lot of times right before surgery, before you're going in to kind of knock it. You don't remember anything. We give lots of fentanyl, lots of Versed. We'll give a Versed push right before we do wound care. We don't want them to hurt. It's gonna hurt, but we try to make it as comfortable as possible. And a lot of times people say, I don't know how you do it because you're dealing with these patients that are hurting. We try to knock them out as much as we can. The Versed, I gave a lady Versed, a little Hispanic lady Versed. She had a burn on her arm. She was cooking and got a steam burn, and it was bad. But we'd give her the Versed, and she'd be like, oh, it hurts, it hurts, it hurts. And we would try to hurry up and get through. And 30 minutes later, she'd kind of wake up and she'd say, you did my wound care already? She didn't remember anything. Now, we have some that do remember. So it just depends on the patient.
So I have a question that's kind of not, related, but so if you have a patient that comes in and their clothing is like polyester it kind of sticks to them, right?
Yeah,
like in
it
a burn
does.
situation, how do they?
Okay, we bring them in, okay, and we bring them in through our ER. Up there, we have our own ER, we have our own ICU, we have our own step down, we have our own wound care clinic. It's like its own little burn hospital inside a hospital, okay? When they come in, they'll come in, the ambulance people or the air people will get them in, we'll put them on this metal bed. It's padded, but it's a metal bed. And we have hoses that we reach down and we start washing them. We cut those clothes off and start washing them. Give them some pain medicine before we start doing that. And we start washing them and getting that stuff off. And yes, we have to pick out clothing sometimes. We have to pick out glass sometimes. We have to pick out, we've picked out needles.